Every other day, someone or anyone out of us suffers trauma. It can be a head trauma, it can be chest trauma, it can be trauma to the abdomen, or it can be a trauma in case of involving the limbs or the lower limbs. Today we'll be talking more about the trauma because overall, the management strategy for coping up with the trauma patients remains the same. We'll be talking in detail about how the liver trauma is going to present to you, how you're making a diagnosis of the liver trauma, and what important steps you have to follow when you are actually encountering a patient of a liver trauma, what initial management should be consisting of, and what are the important surgical steps in case of the liver trauma. So first of all, obviously, you should know what are the different causes for liver trauma. It can be a road traffic accident, it can be a gunshot injury, it can be a blunt or a penetrating injury. Now, the liver trauma is the second most common cause worldwide, which is affecting the most of the patients and resulting in their mortality. Particularly, if we talk about the causes which are involving the liver trauma, we actually divide them into the blunt injuries and the penetrating injuries, right? So the blunt injuries include maybe some kind of lacerations, liver avulsions, or the liver contusions, and they may be because of a fall. Or maybe some kind of crush injuries to the liver, or maybe because of impact injuries as a result of collision. The penetrating injuries, more commonly, they are the gunshot injuries. If we talk about the penetrating injuries and particularly about the gunshot injuries, so the shot is entering through the inter-abdominal wall, and it's affecting there must be the entry wound and the exit wound as well. So sometimes the bullet is stuck within somewhere between the cavity, abdominal cavity, the liver or spleen, or sometimes it walks away through and through, and it goes up through the posterior abdominal wall, and maybe the bullet is exited from behind or the back. So actually, if we are more focused about the causes, we actually divide the injuries into the blunt injuries, and as I already mentioned, that the conditions or the injuries which are put in a category of the blunt injury, that the contusions, the lacerations, or the avulsions, right? And the penetrating injuries are the stab wounds, a sharp wound by a knife, or the gunshot injuries, or sometimes a massive stick just penetrating through the different walls of the liver and causing a penetrating injury. But most commonly we encounter in our setting this stab wound and a gunshot wound. Why it is important to divide these injuries into the blunt injuries and the penetrating injuries, because the blunt injuries, most of the time their impact would be localized, and maybe a kind of a laceration, a contusion, or the avulsion of the liver. But sometimes the penetrating injuries, they're not limited to that particular space. For instance, there was a stab wound along the right costal margin. So apparently, you think about that this is the right hypochondrium or the right costal margin. This is the area which is particularly meant for the liver. And you think that maybe only the liver is being injured, but in case of the penetrating injuries, the extent of the injury is not localized, because there are entry wound, there are exit wound, there are installation injuries, there are deceleration injuries, and sometimes the bullet walks in through and through, and it's also involving the upper airway, or maybe the mediastinum, or there can be injury to the pericardium as well if the bullet is running obliquely. So the penetrating injuries, not only you have to do the explore exploratory laparotomy, but you have to go if there is a kind of airway injury or there is injury to the pericardium or the mediastinum, then obviously you have to do the thoracotomy as well. So that's why this is important to understand if this is a blunt injury or a penetrating injury. So how would you differentiate between the penetrating injury and a blunt injury? So if a patient is coming to you and he was reporting that there was a kind of a road traffic accident, or there was a history of a fall from a high top building, maybe 20 feet or more than that, and you see that there is a kind of a tenderness in the right hypochondrium, and usually there are bruises over the surface of the abdominal wall in the right hypochondrium, then you'll suspect that, oh, it's a kind of a blunt injury. So there can be contusions, lacerations, and avulsions of the liver. And if a patient is coming to you and he is giving you a history that I've got a stab wound, and after a long quarrel between the two groups, or it was a kind of a fight, or it was a kind of a gunshot wound, because there would be the entry wound and exit wound as well, and you think that actually not maybe apparently the patient will be complaining about the right hypochondrial pain, but sometimes if there's a penetrating injury, so they can be injury to the chest as well, they can be injury to the airway, they can be injury to the mediastinum or the pericardium. So that's why it's important to think or to investigate if it was a blunt injury or a penetrating injury. Now, okay, so I'm giving you a kind of a typical scenario. A 26 years old male presented to you as a result of the gunshot injury in an emergency department, and the patient is tachycardic, the patient is tachypneic, and his blood pressure is 80/50, and he's not maintaining his blood pressure. So how would you think apparently there's a tenderness in the right hypochondrium, and the patient is not hemodynamically stable or vitally stable, but there's no apparent bruise or laceration or kind of avulsion which is being visible to you. But the patient hemodynamic status, it was very, very much important, because it will give you a suspicion that there is some kind of injury to the abdomen. Maybe it's injury to the spleen, it's injury to the liver, because there's a profuse blood supply of the liver, and whenever there's injury to the liver, it bleeds profusely, and spleen also profusely bleeds. So either it's an injury to the liver or a spleen. Obviously, you have to suspect if the patient is not hemodynamically stable. Either there would be the two cases. The patient would be hemodynamically stable, or the patient wouldn't be hemodynamically stable. So sometimes if there are smaller contusions of the liver, a patient would be hemodynamically stable, and you'll think maybe there would be tenderness in the right hypochondrium when you're examining the patient. But sometimes there's a massive injury to the liver and massive trauma to the liver, and the patient bleeds profusely, and he's not hemodynamically stable because his liver is internally bleeding. Then it will give you a kind of clinical suspicion there's something going on within the abdomen. And sometimes when the patient actually presents to you, he already have developed the signs of peritonitis, and there would be guarding, there would be rigidity, there would be abdominal distension, and there would be, generalized tenderness in the abdomen, not only involving the right hypochondrium, but when he developed the generalized peritonitis, so the tenderness would be involving the whole of the abdomen. So there are some particular signs that actually going to give you it's kind of clinical suspicion that the patient is actually developed a massive trauma, maybe to the spleen or maybe to the liver. So actually, first, the condition of the patient, the hemodynamic status of the patient, the vital status of the patient is somehow very, very much important, because if the patient is hypotensive, then he will have a compensatory tachycardia, and he will be tachypneic as well, because sometimes when there is a hypotensive shock, then the patient is tachycardic and tachypneic at the same same time, and then you have to do the arterial blood gas sampling as well, and then obviously you have to go to give a supportive management. So how you are actually going to make a diagnosis. There can be, I have already discussed that sometimes there's not only the injury to the liver you're suspecting, there can be injury to the spleen as well, and sometimes there can be injury to the lower chest wall and the pericardium as well. So you have to assess those things as well. And sometimes there can be sweat crushing injuries, like as a blast explosion, right? So if a person is working in some mining, he's working in a mining scenario, and there's a sudden blast explosion, or it's a suicide bombing as well, or so there would be blast explosion, and as a result of that, there would be sweat crush injuries to the lower chest or the upper abdomen, and that can be combined with the rib fractures as well. And when there is some kind of injury to the chest, then obviously there would be haemothorax or pneumothorax, whatever, that would be quite visible in the chest x-ray. So the patient has already presented to you. Let's suppose I'm giving you a scenario that there was a 26-year-old man, and as a result of a fight between the two groups, he suffered trauma to his abdomen, right? And when he is presenting to you, he's actually vomiting, and he is complaining of the severe right hypochondrial pain and some of the mild kind of pain in the left hypochondrium as well. And when you're examining the patient, if we talk about the hemodynamic status and the vitals of the patient, his heart rate is 124, which is obviously tachycardic. His blood pressure is 80/50, which is hypotensive, and he has a respiratory rate of 34 per minute, so that's mean he's also tachypneic. So basically, he's not vitally stable. He's not hemodynamically stable. Right, first thing is that. Second thing, his complaints as well. And third thing, you have to follow the trauma guidelines, right? And the trauma guidelines is advanced trauma life support, and you have to basic life support. So what you do is you do a basic life support primary survey, and advanced trauma life support you do the secondary survey, right? So how you are actually going to assess if the patient, make this thing very clear in your mind, every trauma patient, whatever the region is, it's the limbs or the abdomen or the chest or the head injury, what you have to do is you have to follow some protocols, and the protocols are like you have to follow the basic life support program, which involves airway, breathing, circulation, right? Which is the part of the primary survey. And the secondary survey, then you have to auscultate the chest, and you have to auscultate the pericardium, you have to auscultate the heart valves, and you have to examine the patient, the bruises, a proper exposure of the abdomen, exposure of the back. So actually the first part, which is a basic life support, that is meant for a kind of the immediate primary survey of the patient, if the patient is hemodynamically stable or not. So first, A for airway, B for breathing, C for circulation, and D for, delirium, right? So first of all, you have to check the airway. If the patient is not conscious, or if the patient is unconscious, and if the patient is not breathing properly. So what you have to do is you have to assess the airway status of the patient, right? If the patient is breathing or not. Maybe sometimes you're assessing a patient and the respiratory rate is very less, and the patient is in a semi-comatose or he's presenting to you with an altered sensorium, then what are you going to do? Obviously you're going to check the airway. So how are you going to check the airway? You're going to check the airway. You have to give a patient a mouth-to-mouth breathing. You have to see if there is a kind of the inspiration or expiration, if there's a kind of the abdominal muscle contraction or the movement, respiratory movements are present or not. And if not, if that means that there's a kind of the obstruction somewhere, maybe the patient would be sinus. And sometimes as a result of the trauma, there's a falling back of the tongue. So actually, because of the falling back of the tongue, the airway, upper airway is closed, and because of that there is no entry to that. So what you do is you try to give a mouth-to-mouth breathe to the patient, and you also put the airway, which is usually in emergency with a Goodell's airway. So actually you put the Goodell's airway in the patient mouth, and so that it actually prevents the tongue from falling back and coming over the surface of the trachea. So you need to put a proper airway, like most commonly we're using the Goodell's airway in our setting. Then comes when you're done with a part of the airway, or sometimes if still the patient's saturation is is dropping to a critical level and is not maintaining the saturation, then you have to intubate the patient, right? And by intubation, you means that you have to put the endotracheal tube. And sometimes when there's a kind of a massive trauma to the neck as well, and there's there's engorgement, there's edema to the neck, and sometimes intubation is difficult to perform, and then you have to end up with a tracheostomy. Then comes the C part of the ABCD survey. Then that's the circulation, right? So the circulation is like when the patient is maintaining the BP. So most of the time, if you're suspecting that there's a kind of a massive liver trauma, there's a kind of a massive injury to the spleen, and sometimes there's internal bleed going on, then what you have to do is you have to resuscitate the patient. For instance, maybe you're starting with the colloids, and you're starting the best fluids to give in the emergency is the ringer lactate, right? So the lactated ringers, they are most of the time used in the emergency, and they are building up the BP or immediately. And then you simultaneously you order 10 units of the blood so that you start to transfuse the bloods along with the fluids, like maybe ringer lactate or the hemacil as well. And if the hemacil, when the blood is available, then you have to transfuse the patient. But still, if even with a transfusion and with pitting the patient with a good fluid, the BP is not building up, then ultimately there you have to stop the bleeding, right? And the bleeding can be from the liver, hepatic artery, the hepatic vein, or IVC sometimes also injured, then you have to do the laparotomy. Then comes the D part, which is the delirium. So it's somehow related to the brain. So if the patient is semi-conscious or unconscious, then obviously after assessing the ABC status, you have secured the airway, you have secured the breathing is also, you have intubated the patient, or somehow tracheostomy is being done, airways is patent, and you're done with the circulatory part of the survey, and you have put the patient on a good resuscitation, and now you are trying to rule out the cause. Then urgent CT scan brain should be ordered, so that if the patient is, there's a kind of the 5 important sign: vomiting, loss of consciousness, ENT bleed, nosebleed, or the periorbital ecchymosis, which is also called as a raccoon eyes. So these are the signs which actually tell you about the fracture base of the skull. And for that, you have to order for the CT scan, because along with that, there can be subdural, extradural hematoma as well. And that's why, and it can be most of the time because of the trauma, there's a hemorrhagic stroke, right? So the hemorrhage, maybe the intracranial bleed or the extracranial bleed, they are actually causing or making the patient symptomatic, like with the loss of consciousness or the altered sensorium. So you have to investigate all those things. Then when you are done with the vital part, right, the patient is now vitally stable, right? Although even if there's a kind of a head injury and the GCS is not that, but he's vitally stable, his hemodynamic status is fine, his airway and the breathing is fine, and his circulation is fine, then you have to order for some investigation, right? Okay, you're resuscitating the patient, but the patient BP is not building up, right? Then urgently you have to order suffer, because sometimes if there's a fracture of the femur, so fracture of femur bleeds very, very badly, right? And sometimes if there is a fracture of the femur, 2 liters of the blood, 5 liters of the blood is all in all present in the body. In a whole body, the amount of the blood is 5 liters. So when the fracture bleeds, it bleeds very badly, and a 2 liter of the blood sometimes bleeds. So it's important to resuscitate the patient. Resuscitate the patient with a good fluids, with the crystalloids, with the colloids, whatever available, with the lactated ringers, they are the choice. And if you have hemacil available, you have to transfuse them as well. And the whole blood, obviously, there's no substitute for the whole blood. Then comes the other part as well. If there's a liver trauma, then the patient would be in DIC sometimes, because the clotting factors, they are coming from the liver, and there's a massive trauma of the liver, and there's the patient the patient's liver is not traumatic, and it's not functionally okay, and then there would be dysfunction, obviously, and there would be a kind of a coagulopathy, right? So after, when you are transfusing the whole blood to the patient, then sometimes you have to transfuse the fresh frozen plasma or the cryoprecipitate as well, so that the coagulopathy should be, but that's a kind of a later thing. So we are just focused on primary survey and the secondary survey. So it's a part of the primary survey to investigate. So if you're making a diagnosis, you're suspecting a liver injury, then you have to order for the FAST scan, which is focused abdominal sonography. And in that, what you do is actually, there would be a kind of an intraperitoneal fluid, right? Or sometimes the fluid can be from the liver, the fluid can be from the spleen, but in emergency, if there's a intraperitoneal fluid, then it will tell you that there's something going on within the abdomen. So most important organs which are located in the abdomen is in the right hypochondrium and the left hypochondrium, the spleen and the liver, which bleeds very, very badly, right? So it will give you a kind of a clue, or it will give you, if you're suspecting, it will confirm your suspicion that there is a massive trauma to the liver, there is a massive trauma to the spleen, right? So if you could appreciate, this is the ultrasound, and this is the peritoneal fluid, right? So the blackish color of the fluid in the ultrasound is actually showing you that there is a kind of a massive trauma to the liver. Or maybe massive, if the fluid is present in the right hypochondrium, then you will see that there would be a lot of a fluid around the liver and intraperitoneum as well, or there would be a fluid around the spleen, the left hypochondrium, and the peritoneum as well. So the free fluid in the abdomen usually tells you that there is a kind of an injury going on within the abdomen. So when you're done with a FAST scan, and when you're done with the other, usually the blunt injuries, they present not only with abdominal injury, they may be associated injuries as well, right? And the penetrating injuries, most of the time, they're starting from the abdomen, so they can probably involve internally, maybe the upper airway and the lower airway. So you need to assess the patient as a whole: airway, breathing, circulation, and obviously if there's a kind of any deformity related, maybe a fracture, or so you can either way take it as a delirium, right? So the status of the brain as well as a kind of the subdural, epidural, extracranial bleed. So after you're assessing the patient, you're done with you're now moving on to the secondary diagnosis. So in the hemodynamically unstable patient, usually the diagnosis can be made with a fast scan, because when you're doing the fast scan, you're actually visualizing the whole of the abdomen. So the most important visual organs, the diagnosis can be confirmed by using the fast scan. But in the hemodynamically unstable patient, this investigation is sufficient, and then you have to shift the patient to the operation theater, and you have to do the exploratory laparotomy. Now, if the patient is clinically stable and his vitals are stable, but still you're suspecting, then you should go for the CT scan, which is the computer tomography, or the contrast enhanced computer tomography. So it will actually locate, you can see that this is the part of the liver, and this is the part of the spleen. So you could see that there is a fluid which is present not only around the liver but around the spleen as well. So it's telling you that there is some trauma to the liver and some trauma to the spleen as well. It not only tell you that there's the trauma to the liver, but it actually tells you about the damage to the parenchyma of the liver, the spleen as well, how much of the parenchyma, and plus it's also giving you the information about if there's a hepatic artery is injured, or the IVC, inferior vena cava, is injured, or the hepatic veins, they are injured. And it actually helps you deciding about the management. But you should only do CT scan in those patients who are hemodynamically stable and you are confused regarding from where the bleed is actually coming, because ultrasound is usually shows you more about the organs, especially the liver, the spleen, and the bladder. But a CT will give you information about the parenchymal damage as well, and the CT will give you information about the damage to the vessels as well, like the hepatic artery is involved, the hepatic vein is involved, the bleeding is from the IVC or any other collaterals that are present, or maybe the portal vein. So maybe the portal vein is bleeding. So it will give you a kind of the PET information, but you will do and reserve this test or investigation only for those patients who are hemodynamically and widely stable. So again, you are coming to the management part of the liver trauma, right? We'll be focusing more on a liver trauma, but usually the overall protocol remains the same, which is the advanced trauma life support and basic life support, right? And usually in case of the trauma, we're more focused on the advanced trauma life support, which consists of primary survey and the secondary survey. So in the primary survey, you're assessing the hemodynamic stable status and the vital status of the patient, and you check for the airway, you check for the breathing, you check for the circulation, and you check for any kind of the deformity or some kind of injury to the brain as well. So in case of airway, breathing, circulation, if the airway is not present, put the girdles away, or if the airway is not patent, or either start from the mouth to mouth breathing or finger sweep. So sometimes there's some tiny foreign body which is obstructing the airway. So mouth to mouth breathing, finger sweep, and one thing which is important is head tilt, chin lift. This is also very much important. So head tilt, left chin, lift the chin, then mouth to mouth breathing, then finger sweep as well. Then you have to check, you have to put the Goodell's airway, and if it's still the patient's respiratory effort is not improved, or the patient is not maintaining the saturation, then intubate the patient. Or if intubation is difficult because of massive trauma to the neck or because of adenomatous airway, then you have to do the tracheostomy, like putting the tube right from the trachea and between C3 and C4 rings. Then when you're done with every part, check for the breathing. So if they can be a tension pneumothorax, in case of the tension pneumothorax, because it's more related to the chest trauma. But if there's a massive it's a kind of a tension pneumo or a hemothorax, then you have to needle aspiration is somehow very much important. Put the needle in the second intercostal space to relieve the pneumothorax or tension pneumohemothorax. So sometimes those in those conditions in which there's simple pneumothorax or simple hemothorax, then obviously you have to put the chest tube later on in the fifth intercostal space, right? So that's how particularly fourth intercostal space. So that's how it's important, but you have to take care of the pericardium as well in that. So if when you're done with the AB part, you have to move to the C part, which is circulation, and you give a fluid. So in case of the liver trauma, what is important? Most of the time, the patient is bleeding profusely. Either there are two states: the patient is hemodynamically stable or the patient is hemodynamically not stable, right? So if the patient is hemodynamically stable, then order for the basic investigation, send for the all baseline investigation, blood CP, serum electrolytes, urocreatinine assessing, renal function test, liver function test, PTA, PTDN, or the clotting profile, the coagulation profile is somewhat very, very much important, because after all, you're managing a case of the liver trauma, right? And also send the blood cross match and order to arrange 10 units of the blood at least. And if the blood is not available immediately, then put the patient on lactated ringers, pass 2 large bore IV cannulas, and start resuscitating your patient. Give the fluids as much as you can give. Crystallize the best solution, like the lactated ringers. And then if the blood is available, it's best to transfuse the blood. But still, after the transfusion, if the patient BP is not maintaining, that means there's internal bleed, and you have to do the emergency laparotomy, and you have to shift the patient immediately to the operation theater, right? So after you're done with the primary part, the secondary part is like assessing each and every part, each and every system. You have to start from the CVS, you have to look for the chest, you have to expose the abdomen, you have to expose the back, you have to look for the neck, for the spine injury, for injury to the femur, and rest of the x-rays, which are important when you're assessing the patient. So in case of the liver trauma, go for the fast scan. If the patient is not hemodynamically stable, make it hemodynamically stable. At least start resuscitating the patient. And meanwhile, do the fast scan, localize, but do not wait for the CT scan if the patient is hemodynamically not stable. If the patient is hemodynamically stable, widely stable, then you have a little bit of margin, and you have a little bit of time, and you can order for these investigations to actually check the extent of the parenchymal damage, or to localize the bleeding, hepatic vein or the portal vein or the IVC is bleeding. So remember, associated injuries, at case of the high-risk patients, in case of the stab injury or gunshot wound, also assess the lower chest. Check for the hydrothorax, pneumothorax. Check for the compression rib fractures, or check for the pericardium as well. So the crush injuries are maybe associated with multiple rib fractures. So again, assess those as well. Resuscitate the patient. These are the basic principle, right? So again, starting from airway, breathing, circulation, resuscitate with the fluids, passing the large IV bore cannula, assess the airway pattern, breathing. Intubate the patient if necessary. If there's a massive pneumothorax or tension pneumothorax, and it's causing a collapse of the lung, then immediately put the chest tube. Then assessment of the injury, CT scan and abdominal, especially abdominal CT scan with contrast with a hemodynamically stable patient. And if the patient is hemodynamically unstable, the last option we have is to do the exploratory laparotomy and then treat the cause, whatever it is. Correct. The coagulopathy, usually, when a liver is already damaged, there are some kind of reserves of the clotting factors. They do not immediately fall off, but the patient can go in a disseminated intravascular coagulopathy, right? So always correct the coagulopathy. It's good. You transfuse the patient with a fresh frozen plasma and the cryoprecipitate, and obviously along with the whole blood. So when these units are not available to you, transfuse the whole blood, because whole blood will have these some kind of the clotting factors as well. So you can transfuse them. But when the cryoprecipitate or the fresh frozen plasma is available, then obviously you have to transfuse with these things. And but whatever the site of the laceration is, suture. So the basic management for every trauma case is you have to start from the A, B, C, D. You have to assess the airway, you have to assess the breathing, you have to assess the circulation, and you have to obviously you have to correct. If there's a problem with the airway, correct the airway. If there's a problem with circulation, if there's a problem with the breathing, put the patient, correct the hydrothorax or the tension, pneumothorax, correct that. Chest tube should be placed immediately, and then obviously the circulatory part, and you have to resuscitate the patient. Pass 2 large IV bore cannula immediately. Start resuscitation on both the cannulas. Lactated ringers are the best, but if the blood is available, so always transfuse with the blood available. And wait, keep transfusing till the time you have available with the cryoprecipitate or the fresh frozen plasma, and transfuse the patient with the fresh frozen plasma and the cryoprecipitate. And if the patient is hemodynamically unstable, with all these things, then ultimately, and you have done the fast scan as well, and in the fast scan there's a free fluid in the abdomen, then immediately shift the patient to the operating room and start doing the exploratory laparotomy. Meanwhile, you have to keep resuscitating the patient, keep giving the fluids, keep giving the hematol, keep giving the blood, and meanwhile do whatever exploratory part you have to do, especially for the liver. Sometimes they're like contusions or avulsion or lacerations. So smaller lacerations, they can be sutured. But if there's a massive bleed in the liver, remember you have to pack the liver, right? So you start packing the liver from below. The lower extent would be obviously the diaphragm. So start packing the liver from diaphragm, and pack it from below, pack it from above, and pack the liver from sides. Liver packing is very, very much important, because other than that, it's a massively profusely supplied organ, right? So obviously it's not possible for you to start suturing every little artery or start ligating the vessels, especially if there's an intraparenchymal bleed, right? So for that, you have to start packing the liver, and just pack the liver, make the patient hemodynamically stable, then close the patient if the patient has already hemodynamically been stable, and shift the patient to the intensive care, for 24 to 48 hours. And you have to do the relocal laparotomy after the 48 hours. And you need to assess, you have to leave those packs of the liver, or if there is injury to the spleen as well. So just pack the liver, pack the spleen, wherever the injuries start from packing, or start packing from below, start packing from above, so, and from the sides as well, and then close the laparotomy, and then reassess after 48 hours to check the status, right? And then in the reassessment, if there was a kind of a injury to the hepatic artery or the portal vein, but that can be, later on you can suture it. But the major vessels, like if there was a kind of injury to the inferior vena cava, there's a kind of injury to the portal vein, or then if you are capable enough and you're a good vascular surgeon and you can pack, other than packing, you know how to repair. So after packing, and if the patient remains hemodynamically stable, the major vessels, obviously, they can be repaired if you're a good vascular surgeon along with a general surgeon. But you can also refer the patient to the specialist centers as well. So if there's a diffuse parenchymal injury, again, the packing is the option we have available with. This has been already explained to you. Now, initial management for the blunt and the penetrating injury, they still basically the basic principles, and how you are going to handle the patient in emergency or initially. So that basic management for the penetrating and the blunt injury still remain the same. Still, you have to follow the advanced trauma life support program. You have to follow the protocols. You have to do the primary survey. You have to do the secondary survey as well. So, but what different you have to do in a case of the penetrating injury? Start again from ABC, assess the status of airway, breathing, circulation, right? Meanwhile, send the venous sample, blood samples, send the cross-matched, arrange 10 units of the blood at least, send the arterial blood gas sampling as well. Start resuscitating the patient. The volume replacement is very much important. It's important to replace whole blood, but till the time whole blood is not available, start pushing the fluids with a large IV bore cannula as explained earlier. Send the ABGs, intubate the patient if necessary, ventilate the patient if necessary. Not only the intubation, but intubate the patient and put on a ventilatory support. Put the intercostal chest drain, like the chest tube again, for the massive tension. Tension pneumothorax, or depending upon the condition of the patient. And then if you have time, you can order for thromboelastography and contrast CT if that is available. So if we talk about the thromboelastography, actually, so in case of that, it's actually measuring the function or the coagulopathy, right? So sometimes for that, if sometimes it's intraoperative facilities available, and sometimes it's not. So you're actually assessing the graph comes to you, and you assess the coagulopathy. So for that, in higher centers and specialized centers, it's available. So the normal graph would be like this, but if there is coagulopathy has already being developed, then the graph would be like this, and it will show you that there is a delayed clot formation. This kind of the graph shown in the third place, that will be telling you about the reduced clot strength. And clot lysis graph would be like that, and a hypercoagulable graphs would be like that. So in case of the coagulopathy, as a result of the liver trauma, as a result of the liver dysfunction, then obviously there would be delayed clot forming, and there would be reduced clot strength as well. Because so the graph can be either way, with the delayed clot forming or with the reduced clot strength. But if this option is available intraoperatively, you have the ultrasound available in your OR, then you can order for this thromboelastography. But if that's not available, then obviously still you have to give the patient fresh frozen plasma and the cryoprecipitate. And for the penetrating injuries, obviously you have to do the laparotomy and sometimes thoracotomy as well, because they can be possible that if there was a stab wound or the gunshot, so maybe possible that the bullet has just escaped or exited causing damage to the pericardium or the chest, then you have to assess that as well, and you have to do the thoracotomy. For the blunt trauma, again, the initial resuscitation and the management still remains the same. You divide these in the hemodynamically unstable patients and the hemodynamically stable patients. So in the hemodynamically unstable patients, you have to do the immediate laparotomy, and in case of the hemodynamically stable, you have a time for the CT scan, and you do the CECT of the abdomen where you can assess the parenchymal damage, and plus you can also assess the vascular injury as well, right? If there's injury to the hepatic vein or the portal vein, but that can be if there's a kind of the patient is hemodynamically stable and there's a diffuse parenchymal and the injury to the liver, then you can manage that conservatively. So talking about the surgical approach to the liver trauma, you give a such kind of the incision, which is called as a rooftop incision. So actually rooftop is like this, right? There are two inclining points. So this is the rooftop incision, which is not only covering the right costal margin, but it's covering the left costal margin as well. So if this is the abdomen and you are doing you're assessing the liver trauma. So how you would approach the patient, you give a midline rooftop incision like this, and sometimes there are extension to the midline as well. So it's a kind of the rooftop incision with involvement or extension to the midline as well. Or sometimes it's a midline incision and you extend a little bit on the right with a lateral extension on the right costal margin as well, making it a little bit transverse or the right subcostal margin, exposing the liver. So the most important keys in case of the liver trauma is like you have to pack the liver. This is important, right? Start packing the liver from the diaphragmatic surface. That means that start packing the liver from below, right? So pack below, pack above, pack on the sides. This is important. So that this is the initial thing you can do for the patient. And pack the patient. If the patient is hemodynamically stable, and start assessing the resuscitation status of the patient, right? And when you're done with that part, and you're done with the liver packing, the bleeding is being stopped, close the laparotomy, send the patient to the intensive care unit, and then start planning for the relocarotomy after the 48 hours. So that's what you have to do. And sometimes when there is a massive injury to the important structures, like the foramen of Winslow, this is very much important. When you're doing the laparotomy and you open, it's not the only liver or the parenchymal damage which is bleeding, but there's a major vessel, and it's difficult whenever the vessel is bleeding. Always remember it's very, very difficult to identify where the blood is coming from, and ultimately you have to pack. But after some time, if there is massive bleed, then you have to follow the Pringles maneuver. And what is the Pringles maneuver? That in the foramen of Winslow, you have to ligate or you have to pack the foramen of Winslow, right? For that, pinch or pack or ligate the foramen of Winslow, because the portal vein, hepatic artery, they are located in the foramen of Winslow and in the callus triangle. So always, because they are exiting, it's a point from which these major vessels are coming. So do the Pringles maneuvers to stop the bleeding, and ultimately do the packing. And for the major vessels which are bleeding, and you're in a specialist center or you want to repair, then you have to go for the veno-venous bypass. So how you do the veno-venous bypass? Actually, the femoral vein or the veins of the lower limb, they're coming into the IVC. So you have to divert the blood, right? So because they're coming from the IVC, and the portal vein is also draining into the inferior vena cava. So what you do is the femoral vein is also draining into IVC. The whole of the blood is draining to the portal vein, and the portal vein is actually draining into the IVC. So you have to create a veno-venous bypass. So how you create the veno-venous bypass? Actually, through the long saphenous vein, you cannulate the femoral vein via the long saphenous vein, and you actually divert the whole of the blood into the superior vena cava instead of inferior vena cava. So actually, after diversion, you have a kind of the space available for the repair of the portal vein or the hepatic artery, whatever the available you have. So there can be some kind of complications of the liver trauma. It can be intrahepatic hematoma. Usually, you do not do anything with the intrahepatic hematoma. Usually, it resolves spontaneously on its own. There can be a liver abscess. Sometimes abscess is huge because there can be post-operatively or after the trauma. There can be surgical infections, right? So a liver abscess can be formed. So give a good hydration and give a good antibiotic cover to the patient and wait. If it's not resolving, then ultimately you have to drain the abscess. Bile collection, again, the option you have is drainage. Biliary fistula, for that, you have to operate, obviously. Hepatic artery aneurysm, ultimately, you have to involve the vascular team and you have to get rid of the aneurysm. In the past lecture, I have told you how to deal with the aneurysm. A bypass should be created, or you just get rid of the aneurysm, or you block or you ligate that vessel. Atriovenous fistula can be formed, atriobiliary fistula can be formed, or they can be fulminative or hepatic failure sometimes. And sometimes like we divide the liver into zones, and sometimes you have hepatectomy is the option. Sometimes one zone or a partial hepatectomy or the total hepatectomy can be performed when there's a lot. But usually what you do is you pack the liver from all around and close the laparotomy and give a relook laparotomy after the 48 hours and then assess. And if there's a major vessel bleeding, then obviously you have to do it yourself if you're competent enough, or you have to ask for the vascular surgeon to repair there's the IVC or the portal vein, and you have to repair the vessel or start suturing. There can be long-term complications of the liver trauma. So we divide them like on the immediate complications, like we have already discussed about the biliary strictures, biliary fistulas, hematoma, liver abscesses, but there can be late complications which are involving the biliary stricture. So it can be a segmental stricture or it can be a lobar stricture. Or sometimes a structure associated with the atrophy, and along with that, the part in which the stricture is present, that undergoes the atrophy. But the remaining parts, they undergo compensatory hypertrophy. And obviously, you treat them accordingly. And sometimes there can be extra hepatic biliary bile duct stricture. So sometimes it's not that the stricture is not within the liver, it's somehow outside, and it's involving the channel, the biliary channel. So obviously this can be associated with obstructed, and what you do is like you put the patient on you put the stent for the drainage. That's how you actually treat that patient. So like the complications, they are being managed. What kind of the complication is present, and maybe it can be conservatively be managed, or you have to do the surgery. So for about the obstructive jaundice, obviously you need to the biliary drainage should be the option, right? So what you do is you do the ERCP, which is endoscopic retrograde cholangiopancreatography, and you put the stent by that, or you do the balloon, endobiliary balloon dilatation, or sometimes when it's not possible to deal with this with the ERCP or balloon stenting, then obviously the surgical option, which is Roux-en-Y hepatojejunostomy. So you create a bypass channel between the jejunum and the liver, and it's actually bypassing the whole of the part. So that's about the late complications. So today, what we have studied today, today we talked about the liver trauma, the basic managements for the liver trauma, and the options, surgical options we have available. So the first thing is you have to pack the liver for 24 hours to 48 hours, and after the 48 hours, you have to do the relook laparotomy, and you have to assess the patient after that. So that's all for today. Thank you for watching sqadia.com. Keep watching sqadia.com, general surgery course for Dr. Sana Khan.